Hello and welcome to this Facebook Live seminar. My name is Dawn Stevens and I am the Medical Education Manager for Essity. I'm a registered nurse with a specialist interest in tissue viability and lymphology. Today we are very privileged to have Jamie Gain, an adaptive athlete, join us, who will be talking about his incredible journey as a patient. From a young age, Jamie has been a patient. His journey is an inspiration to us all. Tonight he will talk about his story, being a patient, and how that led to him undergoing an amputation and how he dealt with the challenges of incontinence. This seminar is supported by Essity. Contact information available at the end of the presentation. We'll now move on to the presentation entitled Wound and Continence Care, A Patient's Perspective. So before we start and we listen to Jamie's story, I just wanted to highlight some of the learning objectives we're going to attempt to cover this evening. First of all, we're going to highlight the factors that may impact upon a patient living with a condition or a disease and how a holistic assessment can help. We're also going to look at how healthcare professionals should consider when caring for a patient with a wound or continence challenges and how they can optimise their well-being and healing. And then there'll be a live discussion between myself and Jamie talking about the impact his health has had on his overall quality of life. But before we get into the factors affecting wound healing and the factors that affect incontinence, let's just touch on some of the statistics and some of the costings around wound care and continence. Now, in 2015, Guest et al. Did a health economic study, and they identified that managing patients with wounds and their associated comorbidities was estimated to cost the NHS around 5.3 billion per annum. Now, to providers and commissioners, the delay in any wound healing could relate to resources being used inadequately. So why are we bothered? In 2018, there was a further study done by Guest et al. Who identified that we do more than 10 million operations per year in England alone, and the majority of those involved in incision. Now, the paper suggests that unhealed surgical wounds accounted for 11% of wounds managed in the NHS, and dehiscence following primary closure accounts for 26 to 28% of all wounds requiring continued nursing intervention. So it's really important that we get wound healing right first time. Now, from the burden of wound studies, the original one in 2015, they identified that a lot of patients within the data hadn't got an accurate wound diagnosis. There was comorbidities considered, and we need to consider those comorbidities so we can optimise the patient's ability to heal. We need to use the assessment tools that are available to us. So, for example, if we had a lower limb wound, we need to be doing a complete full vascular assessment and completing that Doppler ultrasound if it's appropriate. We need to be putting in structured care plans and consistent dressing selection, and we need to have clear healing objectives with realistic timeframes and goals. And we need to have that continued reassessment, and we need to know when to involve those senior clinicians to help us with those challenging situations. Now, if we think about incontinence and we talk about the prevalence of incontinence, the figures estimate that around 14 million people are affected. 900,000 of those are children and young people who suffered from bladder and bowel dysfunctions. And what we say there is that if anybody over the age of 5 should be deemed as being continent, so at 5 and over is where we would be picking up that number. 6.5 million people have bowel problems, and 5 million women in the UK are affected, along with prolapse, which costs the NHS around £200 million a year. Obviously, we talk about that 14 million people being affected by bladder control problems. We know that urinary incontinence is more common in women, aged 85 or above, and the estimated point of prevalence range is roughly between 35 and 60%, obviously increasing with age. And it's suggested that women are 3 times more likely to experience incontinence than men. But the big question here is that an accurate prevalence, or actually is it due to lack of evidence and actually lack of the studies out there to actually justify the extent of the problem in terms of male incontinence? It's also important to recognise that men experience incontinence differently to women, so we need more evidence is needed to help establish those exact causes and the solutions for the male population. Now, incontinence is not life-threatening, but it does have a major physical, psychosocial and emotional consequences for the individuals and their families, and obviously it does have a considerable impact on society as well. And obviously there is limited up-to-date information on the cost to the UK. But if we take the 1999 and 2000 figures, which are extremely old, what they were suggesting is that actually treating clinically significant urinary incontinence is a cost of 536 million, and 233 million of that is for women alone. So take today's figures, that figure is obviously very, very underestimated. So let's have a look at the patient. I'm going to cover a few slides now that are going to look at the patient as a whole, assessment and the factors, but we're not going to go into too much detail because I'm sure that actually you're all here tonight to hear Jamie's story. So let's set the scene, let's talk about what impacts a patient and how we can help. So when we look at the patient, what is it that we really need to know? Well, some of the key factors are things like we need to understand the patient's mobility. We need to understand where the patient wants to be in terms of mobility as well. Is their condition hindering their activities of daily living, and how can we come up with a strategic plan for them to ensure that they get where they need to be? We need to understand what's happening with their regular activities of daily living. We need to really delve into that and understand what they need to do on a daily basis, what they want to do on a daily basis, and see if we can't help prevent that from being limited. We need to also understand their support network. We need to understand what support is available to them, and it may not be family, it may be friends, and it also could be external services as well. We need to make sure that we've established that. And also their ability to be concordant with the device or the treatment recommendations that we make. I really like this photo because this gentleman here, he obviously clearly likes gardening, and depending on his health condition would depend on whether he could achieve that. So that might be the one factor that actually could be the difference between his psychosocial being a positive or being a negative. So let's look at Nancy Roper. Everybody will remember Nancy Roper, Logan and Tierney. I think your first year of nursing, I remember it embedded in my brain about the 12 activities of daily living. But it's really important, and actually from a continence perspective and a wound healing perspective, every single aspect there could have an impact on the patient. So it's so important when we go through the 12 activities of daily living that we ask them about these things and what's impacting them, what their baseline is, and how we improve it. There's a new best practice statement that's just been launched that talks about male incontinence and male continence problems, and in there is a case study that talks about a taxi driver who actually had prostate surgery, developed incontinence, and he nearly gave up his business because he didn't feel he could carry on working because he didn't have the correct support network in place. Obviously, if we'd identified some of the problems and some of the things that was happening to him, potentially we might have been able to optimise his ability to keep going. The big thing with him was that actually he prevented himself from drinking, so he thought if he didn't drink, he would limit his incontinence, but actually all that did was aggravate his bladder further and then ended up with lots of water infections and lots of infections requiring antibiotics, and then we have the risk of obviously other complications, including the potential risk of sepsis. So when we think about patient-related risk factors, we're always going to consider things like age, nutrition, the hydration, any underlying diseases. Then we've got medication, psychosocial and pain. So if we were to synopsise those, age is always going to be the biggest risk factor because with age comes wear and tear. So from a wound healing perspective, you have that the skin may become thinner, the wound healing process takes longer, the patient's immune system may not be as good as it was, and their overall transport system may be limited. If they've not nutritionally sound, so if they've not got a good diet, obviously we're not getting all the growth factors and everything we need to heal that wound. And most importantly, our patients should be hydrated. A patient that's dehydrated has a reduced volume going around the body, and then that also limits the amount of growth factors for wound healing, but from a continence perspective can actually increase incontinence rather than prevent it. Patients are living longer, which is great. We are living with multiple comorbidities, but come with that is medications to help stabilise those comorbidities. So again, we really need to understand, would any of those medications actually hinder or exacerbate things like continence or exacerbate the prevention of wounds from healing? So I've put up here a couple of slides that really talk about continence-related risk factors. So you'll see here, there is a long list. So we've got the nocturnal and we've got the neurogenic. So if you take the nocturnal, for instance, we've got things like alcohol intake, we've got night sedation. And if we think about night sedation, it may be one, that the patient may be drowsy if they wake up in the night. Number two, sometimes the message doesn't get to the brain, that obviously triggers for the bladder to empty, or may trigger falsely. So ultimately, that can cause incontinence. It could be that it's neurogenic. So if we've got patients that we're treating that have maybe had a stroke, maybe you suffer with Parkinson's disease, or they may have other neurological conditions, that can interfere with the messages that are going from the brain to the bladder, which can cause problems with continence. We then have things like functional incontinence, we have stress incontinence. Now, if we take functional continence, we probably think about the elderly. It doesn't necessarily have to be the elderly, and I think incontinence is sometimes seen as a complication of ageing, and it certainly doesn't have to be. So if we have a patient who's obviously maybe potentially was sitting in one area of the lounge at a nursing home, and we move them for benefits to their overall well-being, but actually that's further away from the toilet, or they're not used to that specific environment, that can have a negative effect on their incontinence. It might be that actually they're partially sighted. It might be that actually by putting a good signpost on the toilet door so that they can see that actually, yes, that is the toilet. Or simple things like changing the colour of the toilet seat. That's a really good one, because people then can identify that that is where they need to go. Because often toilets and bathrooms, all the utensils are very much the same. It could be that you're suffering with stress incontinence. And this can be for a number of reasons. And as you can see on the list, there's things like having a chronic cough, maybe COPD patients, for instance. It could be that you've had multiple pregnancies, childbirth, or going through the menopause. Actually, when you go through the menopause, that can have an impact on your pelvic floor, and it can have an impact on your bladder as well. Or it might be that actually you've had a prostatectomy, and then actually you've got problems with incontinence post-surgery. And then finally we have the urge incontinence. So this is where you have that sudden urge to go, and obviously people sometimes might not get to the toilet in time. It might be that they've got suffering with diabetes. And if their diabetes isn't controlled, what you'll find is that they will drink more from the thirst aspect, and their bladder is filling up too quickly, and then they get that urge incontinence. So by stabilising their diabetes and their comorbidity can help with obviously helping to improve their continence. Also, diabetes is related to wound care. A patient with diabetes, we need to ensure they're stable, because that can have an impact on their ability to heal. So now we're looking at some of these wound-related risk factors. So how old is the wound? Think back to your phases of wound healing. The body goes through a complex sequence of events so that that wound can heal in a timely manner. So depending on how old the wound is will depend on actually its ability to heal. If you've got a wound that's healing within the 21 days, as we say, of the phases of wound healing, that's fine. If that wound is now 3 or 4 months old, we need to go back and do a holistic assessment to understand actually what is preventing that wound from healing in that timely manner. And is it a comorbidity? Is it a factor that's preventing that? It could be that actually the wound is contaminated or infected, or we've got devitalised tissue in that wound bed. All of those things will be related to a factor that is causing that to happen. So it's important that we look at that patient as a whole. We need to think about the impact on the patient if these factors are not considered. The emotional impact, so that altered body image, the depression aspect, so feeling low in mood, maybe relationship difficulties. Patients, it can really have an impact on the patient's relationships. It can have an impact on them wanting to socialise with others. They can become very isolated and maybe not want to socialise with friends and family. It could have an impact on their financial situation, employment limitations. As I mentioned, that taxi driver felt that he couldn't work because he couldn't get on top of his continence. It could be that actually they're unable to pursue those activities of daily living. It might be that we reduce their mobility. It's not uncommon for a patient, specifically a patient with incontinence, that then have an increased risk of falls. So how can we optimise our patients' well-being? Well, we need to obtain the diagnosis. We need to be able to have a diagnosis to be able to evaluate the care. We need to really ensure that we have realistic goals that are set, but that actually can be achieved by the patient as well as what we're trying to achieve. It's kind of meeting in the middle. We need to really understand patient expectations so that we can start that partnership planning. Make sure that we look at lifestyle changes if they're needed. And we need to really plan before we commence. We need to make sure we've got everything we need to be able to achieve that outcome. So equipment, any human resource aspect. It might be transport, for instance, or it could even be down to clothing. We need to ensure that we put everything in place properly so that we can make sure that that patient can achieve the objective we're setting. So I'm now going to hand you over to Jamie. Jamie has agreed to come and speak to us tonight, which is a pleasure. And he's going to talk about his journey. So welcome, Jamie, and over to you.
Thank you very much. It is an absolute pleasure to be here and to be able to access so many people who are willing to learn not only about my story, but also about the issue of incontinence, continence and wound care at the same time. So thank you very much. Now I'm going to give you a little bit of my own history to give you an idea, and I suppose it's a little bit strange to have a 25-year-old sat in front of you talking about continence and talking about wound care, but here we are. Sort of 18 months ago, I never really spoke about any of these issues at all, and it was only with a connection through Essity that I thought, okay, maybe this is my time to shine. This is my time to be able to open up the doors and allow other patients to not necessarily have to go through what I went through. So about the age of 9, I developed a chronic pain condition. I was walking around in Disney World and all of a sudden my feet collapsed from under me. We went back to the UK, I went back to my GP and said, what's going on? My feet are in so much pain. And they said, oh, we don't really know what's going on, but we'll take you to a physiotherapist. I went to the physiotherapist. Unfortunately, that didn't really work. And I went through a process of going through tests, all sorts of things, until it got to an operational stage. And they eventually diagnosed me with a condition called complex regional pain syndrome, CRPS, which is effectively the way that your brain interprets pain. So for example, you get a cut on your hand, your brain and your hand are sending signals to each other. When that cut then heals, your brain isn't sending those signals or not picking up those signals, and you can start to use your hand again. But what happened with my foot was that even though I had sort of a fully functional foot in terms of biologically, my brain was still telling me that I was in pain, and as such I was a full-time wheelchair user from a very, very young age. I couldn't use my foot at all. I couldn't get it wet, I couldn't wear shoes or socks, and as a result my foot looked a little bit like that. It was pretty purple. As I said, I couldn't wear shoes or socks, couldn't get it wet. Even say the bed sheets at night were an absolute pain. Trying to sleep in the summer, if I had a fan touch my foot, I had to switch the fan off because it was just too much pain. If I wanted to prepare for a hospital appointment, I would literally have to be in bed for a few days just to allow myself to have enough energy, not be any pain, to actually be able to get to that appointment. And when I was about 16, I went to the doctors. I'd already had about 25 operations by this point. And I said to them, well, what are you going to do in order to solve this pain? And they said, oh, well, we're going to do this operation and this operation, and if that doesn't work, then amputation is on the cards. And I kind of said, on the cards? No, I want amputation right here, right now. Well, maybe not right here, but right now would be nice. And they kind of said, oh, okay, you're only 16, you don't really know what you're talking about. Let's just see how you go. And they decided that one of the operations they were going to do was that they were going to do a spinal cord cut. So they were going to go in underneath my armpits and start snipping away at my spinal cord until I couldn't feel my leg. And the idea was then that if you don't have that nerve supplying that foot, then your foot isn't going to be in any pain. Therefore, no problems with your pain, you're all good. And as you can imagine, that didn't really work. As a result, I had no consultation before the operation, with the exception of, we're going to cut this cord, it will be great. There's a potential it might not work, but it will be fine. And what I found actually was that I was left with double incontinence. And it started at first that I automatically had a catheter put in straight after surgery. And they said to me, that's fine, cool, let's take it out now. And when I went home, I kind of realised, oh, this isn't right. I'm still not, I still don't have full control. And they said, oh, that's fine, don't worry, that will calm down. Weeks later, it still hadn't calmed down. Months later, it still hadn't calmed down. And I thought, this really isn't right. I started Googling it, and what I found actually was that there was this word called incontinence there, but I thought, no, that's definitely not me. I looked at all the images, and they were all sort of stereotypically older women, and I thought, well, I'm not an older woman. This definitely can't happen to me. I then went to my friend's mum, who was a nurse at the time, and I said, I'm having these issues. What can I do? And they kind of said, oh, well, there are some pads and things you can buy, but, I wouldn't worry about it too much. So I started sort of almost experimenting with pads and seeing kind of what worked for me. I ended up in my own routine, and it kind of was manageable. But what I found was that the financial strain was really quite difficult. If you think I was 16, I was trying to do my GCSEs at the time, trying to deal with toilets within a school setting, not set up for wheelchair users in the first place, and not set up for someone with continence issues. It was extremely difficult. But putting the continence side of things to the side, I was still adamant that this amputation was the right thing for me. And after surgery, after surgery, after surgery, I then eventually managed to convince the doctors to amputate my foot. It took about 6 years to convince them. But in July, I had my first amputation, or what was meant to be my amputation, which was unfortunately cancelled, and then rescheduled again for September 2016. So just about 3 years ago, almost to the day actually, I had my leg removed. And let me tell you, it was a breath of fresh air. And there aren't many people, I'm sure, that sit in front of you and say, having my leg amputated was the best thing that ever happened to me. But by God, it's true. As soon as I woke up from the operation, I noticed my pain levels were so much less than what they were before. I started to wean off my medication that I'd been on from a very, very young age. And I started then to look at, well, what can I do to walk? How am I going to get started with this walking thing? Until this point, I hadn't really spoken to any medical staff about my continence issues, because I just figured, oh, it's just something that I can kind of manage myself, but it will be fine. And I thought, when I had my amputation, well, I'm going to be in hospital for quite a long time. And I was in as an inpatient for about 2 months. So I decided I'm going to disclose my continence issues. First time ever, thought, great, this is what I'm going to do. And it didn't particularly go as well as I would like, shall we say. As I said, I got myself into a routine, and what I found that actually as soon as I got into the hospital, people were automatically trying to get me onto their routine, using their pads and using their system. Well, I knew exactly what had worked for me. I knew that if I ate at a certain time, this was how I was going to manage it, this is the amount of pads I need, these types of pads, this is how I dispose of it. And I found that the nurses weren't really open to discussing that with me. They were very much, here are a whole load of pads, go sort yourself out. If you need any help, great. And things like putting used pads in the bin, in the toilet. They said, no, you can't do that. You have to put it in the bin, that small patient bin you get that's or bag that's attached to your desk. I had to put them in there. And of course, for someone dealing with double incontinence, to have to put used pads in a bin right next to their bed when they're in a communal ward was really, really very difficult. I say it's the first time I had disclosed my continence issues. It's the first time when I was an inpatient. Previous to that, when I was at university and I was about 18, I really struggled financially with the cost of pads, and I thought, I cannot keep this up. I was going through maybe £30 worth of pads a week. And when you're thinking of a university student living on noodles, that's not an expense that you really want to go through. So I decided to go to my continence nurse, or go to my GP with then a referral to the team. And what I found was that after a while, I did manage to get sort of the help that I really needed, But it was a case of, I felt like they had a system in place where they say, this is the pad that you start with, and everybody starts with this pad. And then once you've done that and you've decided it didn't work for you, then we're going to move on to the next one, and then the next one, and the next one. At that time, I was drinking 4 or 5 litres of water a day. I knew that the smallest pads weren't going to work for me, but they weren't open to actually any suggestions as to, oh, okay, well maybe we should reassess this. So after about 6 months of going through these pads, I thought, no one's ever going to listen to me. And it wasn't until I turned up to the appointment and said, this is what I've been using in my own, from my own pocket. What you've been giving me has not given me any support whatsoever. This is what I need, give it to me. Otherwise I'm just going to leave. Because I was still spending the money. And at that point they kind of said, okay, great, we're going to listen to you. And I think actually, given that I had so much confidence in my own care, that really stood me in good stead. But it was particularly difficult. Now, fast forwarding to when I had my amputation, my recovery really wasn't very easy at all. I had so many problems with my stump, various issues with hospitals, unfortunately losing my test results and losing blood results. And when I turned up to the rehabilitation hospital, I had this sort of slight niggle in my stump. And if you're eating dinner right now, you might want to sort of look away and come back to these pictures later. But my stump started to look okay. I had my wound, and providing that my amputation was my choice, I was in the optimal position. I was a young man, I was very healthy, I was athletic. I thought, great, I'm going to have a great stump, a residual limb. And it started off being a little bit difficult, and it went from that, from all sides. And you might be able to see in that picture that there is a slight hole, and I highlighted that to the nurses at the time because it kept weeping. And that hole then started to get slightly bigger, and as I highlighted it even more, and eventually it got to the point where it was 5.5 centimetres deep. I remember the nurse having sort of one of those, the type of things you put in your ear, cotton buds, and popping them in my stump, and it just kept going through the hole and through the hole, and then until she pulled it out and said, oh, it's about 5.5 centimetres. And of course, if you think a residual limb is maybe this big at its most swollen, and 5.5 centimetres as that, it was pretty shocking. And I found that they weren't necessarily giving me the care that I would have hoped for. My stump continued to get worse and worse, and again, I wasn't receiving any care. The nurses weren't supporting me with my continence, and they weren't consulting me or being helpful at all with my stump until it sort of really, really opened up. I knew that surgery, I needed some kind of revision surgery, and unfortunately I was sort of passed from surgeon to surgeon who didn't want to take on my case because I was just too complex. Eventually the hole kind of closed on its own. I was having to go to the nurse every day as an inpatient, and in January 2017 I actually left hospital. I remember the picture is me within a jacuzzi, and it was the first time that I'd gone swimming or been in water for so many years, and I remember just sort of feeling that relief. This is a picture of my stump once it had healed. So we talk about an optimal stump being the muscle on the end of the bone, which means that when you're walking in a prosthetic leg, you then have that little bit of protection, whereas I didn't have any protection whatsoever, and I needed that revision surgery for it all to be good. Now, I always thought, I don't want to let an amputation sort of rule my life, and I started getting involved more and more with sport. I started doing these crazy things called Tough Mudders and other obstacle races. So for those that don't know, it's a sort of 10 to 12 mile obstacle race with 25-ish obstacles. Anything from a 10-foot wall to an ice bucket filled with water, go down the slide into ice, get out the other side and keep running. And I started walking on a prosthetic leg. And I started walking these Tough Mudder courses on crutches. I then moved to walking it with a standard foot without any support, and then eventually I was given a running blade and I started running the courses. It became a little bit addictive, I can say, and to this point I've completed over 75 events and I am enjoying them thoroughly. I mean, obstacle racing is just one of those things I absolutely love. Throughout all of this, I never received any support from any sort of continence team. I was under the continence team's sort of care as such, and I was getting the pads delivered. That was fantastic. But when I said to them, oh, I'm thinking of doing this 12-mile obstacle race through water, etc., they kind of put their hands up and said, well, we don't really know what you can do. You definitely can't do that with double incontinence. That's just not possible. You should just go and realign your dreams. And I kind of said, that's not right. I'm going to figure out a way. I did a little bit of Googling. I spoke to some other people and actually figured out a way for me. At no point did someone say, oh, actually, you know what, I don't know, but I know someone who's a little bit senior to me who might know someone else who might know. No, none of these conversations ever happened. And I was still struggling with this sort of lack of support. In August 2017, I also started judo again. I started at a very, very young age, and I started to compete nationally as well as internationally. And to this point, I'm now ranked second in the world for judo. And I compete with one leg against those with two legs. So it's certainly a challenge. And again, the continence team didn't really know what to do with me. Well, you're doing a contact sport, so how do we manage you with incontinence? And it was just through sort of my own headspace I said, well, I need to sort this out. In January 2018 is when I started really opening up to these continence issues. And when I found that I had a really great pad that was working for me, but because I was a wheelchair user and then had gone to sort of start walking and start running, I needed a reassessment. And as such, I had the continence team visit my home, and they kind of made a joke. They said, oh, well, you know, you're doing all this sport and you're doing all this physical activity. Wouldn't it be funny if you walked around with a tenor top on and we can help you out? And I said, that's great. Yes, please. And at which point they said, great, we're going to help you and support your journey. So 2018 was the sort of the time in which I started my connection with ST, and I started being more open about my continence issues. And at the same time, I also started being really open with my friends about it. And what I found that was this perception that young men don't talk about continence. And, oh, if you talk about continence or incontinence, then your friends are going to think this and your friends are going to think that. Well, actually, that was completely in my head. None of my friends, when I told them, were sort of disgusted by it. They were all really, really supportive, to the point where I imagine some of them are watching this video. Hello. So I started this connection with Essity, and I decided that 2018 was going to be a crazy year full of events where I was just going to try and prove to myself what I was able to achieve, and also prove to those that had told me, you'll never do this, that I was able to do things. So I completed my first marathon in the April, and I started competing at the World Judo Games, where, as I said, I'm ranked second in the world currently. I also competed at the World Obstacle Course Race Championships. I competed in European Championships earlier this year, and I have the World Championships in 2 days' time. So hopefully that will do really well. 2018 was a crazy year for me, and 2019 is almost as crazy, not quite as bad as last year. I'm taking a rest slightly. But I've got the World Judo Games next year. As I said, I've got the World Championships at the end of this week. And actually, it's really opened my mind as to, I had a really difficult journey with both wound care and continence. And actually, I was told throughout time that, well, this is how we do it. This is what we do in order to support people like you. Even though we've never seen anybody like you, but this is what we do. And I'm trying to prove to people, actually, it's all well and good actually having that as a benchmark and having your systems in place that say we go from this pad to this pad to this pad. But actually, I'm a person, I'm an individual. And as part of my journey, I've self-managed myself through that. And I think there are a lot of people that wouldn't. So I think it's certainly worth looking at the patient. And okay, you might not get all your patients doing crazy Tough Mudder runs, but actually everybody is an individual. And I think it's certainly worth looking at that. Thank you.
Wow. What can you say, guys, to that? Such an inspirational journey. And, you know, congratulations, because you've come such a long way in quite a short period of time, even though it doesn't seem that way for you.
Yeah.
So, guys, what we're going to do now is we've got a few questions that me and Jamie are going to discuss now, just to delve a little bit deeper into your journey, because it is very inspirational. I think everybody will agree. So I think the first question that I'd like to ask is, do you ever think that a patient is non-compliant, or do you think it's more of a misunderstanding about what is expected of them, or maybe the care plans that are put in place?
That's a really good question, and I think that patients aren't non-compliant. So I think every patient wants to be able to do something for themselves. I don't think you have any patient that stands up and says, I do not want help. Even though they might appear like that, it's probably a reflection of, I want the help, but I don't like the way in which you're presenting it. I'm not keen on the way that you want me to go down this path. I'm not comfortable. And I think sometimes that can come across as non-compliance. But I think in every patient, there is a wish and a want to do something.
Yeah. And maybe we need to probe you guys a bit more.
Yeah.
To kind of coax
Absolutely.
it out of you.
Yeah. And I think so many times nurses and practitioners say, well, these are the questions I ask, and these are the set 10 questions that I ask, and I'm not going to go outside of that.
Yeah.
Well, actually, okay, you might have your 10 questions that you need to ask, but within those 10 questions, there are so many different ways in which you can word that and treat the individual as an individual.
Yeah, no, I agree. Obviously, during your presentation, you mentioned that you had to purchase your own continence products for quite a while because you weren't getting the right absorbency, and you needed, obviously, drinking 4 litres a day because you're an active person. You need something that's going to obviously hold that. So tell us a bit more about that in terms of how many different variations did you have to go to before you found the right one for you, really?
A lot is the simple answer. As I said, it was kind of a base of, let's start you with the really, really small ones, the sort of tiny pads that sort of fit in your hand. And I spent a long time just saying to them, it doesn't work at all.
Yeah.
And they were very fixed on, well, okay, this is what we think you should have. And even when I agreed with them, I also had to say to them, great, that's what I'm going to have Monday to Friday, but what about when I'm running a marathon this weekend? What do I need for then? What about if I'm in the gym? What if I'm doing this? I need a different thing for this. And it's almost like a failure to adapt to myself and my situation. It was very much, cool, we found that one product is going to fit you through all of your scenarios and you're not open to anything else.
Yeah.
So I think I have now found the right sort of setup for me, which is absolutely fantastic. And I now have a very good team behind me that are there if I have any questions. Yeah. And I'm just very grateful that I've managed to find that.
Brilliant. Obviously, throughout the whole experience, and you were in a wheelchair for quite a while as well, weren't you? Which obviously would have been a real challenge for you. Did you ever suffer with any skin damage in relation to your continence? And how did you deal with that? It imagine it'd be quite painful.
It was. I mean, it was painful and it wasn't painful. So because of my spinal injury, I don't really have that much feeling. So it was actually quite difficult to manage. Okay, I'm in a wheelchair and I'm sat down all day and I've got double incontinence. I'm going to have sores in certain places that I can't see, that I can't feel. Yeah. And it wasn't actually until someone told me, you need to be checking yourself every day, every time, that I started to think, okay, well, maybe this is something I need to do. And I did end up with some pretty horrible instances of skin breakdown. And I found a barrier cream, and there were some really fantastic Facebook support groups for incontinence. And I just started telling people, I'm starting to have this issue. And initially I started it on an anonymous account. Yeah. And then once I had the confidence, once I knew people were there to support me, I then went through my real Facebook account and said, I'm having this issue. What does anybody use for this cream? But I don't get any support from my continence team with that. It was just, the one thing they said to me was just check yourself. Yeah. Which I do, fortunately. And I've got a really great barrier cream that kind of works for me.
Brilliant. And obviously, alongside obviously struggling with the continence issues, you underwent an amputation, which obviously for you was a positive. That's what you wanted. Obviously, as we've talked about, the wound healing process is very complex. So it was a challenge for you to get to the end point, wasn't it, generally? So how did that make you feel emotionally, psychologically, whilst you were going through that?
It was really challenging. And I think my amputation was obviously my choice, and I think that anybody that goes into an amputation or a serious injury or a serious operation, it takes into account, okay, what's the worst thing that can happen? The worst thing for me was I have my leg amputated, I'm still in exactly the same amount of pain, and I'm not able to walk. Yeah. And I fully accepted going into amputation that, great, there's a potential I'm going to be in a wheelchair for the rest of my life, still be in loads of pain. Got that. What I didn't anticipate was you're going to spend 2 months in hospital, and I can take all the pain in the world, but putting a 21, 22-year-old on a mixed ward of neurological and amputees is really, really challenging, and I really underestimated how difficult that would be, and how difficult it would be to be surrounded by other amputees who were, say, 50 years older, who'd say had diabetes, who were severely overweight, who were progressing at a much higher level, a much faster pace than I was progressing, and I didn't really take that into account. And seeing other people walk on prosthetic legs when you're sort of sat in a wheelchair with wound problems was really challenging.
I imagine it's quite frustrating.
It was very frustrating, and being quite a fit young man, the team didn't really know how to deal with me. You know, they said, right, great, we're going to do these physio exercises. Let's do some ball presses with a 1 kilo ball. Oh, okay, you can do that. Let's do it with a 10 kilo ball. Oh, our balls only go up to 10 kilos. You know, it was quite challenging for the team as well. But I think once I sort of started, it was really difficult at the time, but once I started walking, once I got my prosthetic leg, it's kind of all in the past. And fortunately, I don't really think too much about that, and I can't remember being in that situation, however horrible it felt at the time. Yeah,
I can understand it, sort of, block it out almost. At any point, obviously, you mentioned about the fact that you were told, really, you shouldn't probably be doing your mudder, and you shouldn't have been doing this. Obviously, you've proved everybody wrong. How was that a determination in yourself that you were going to prove everybody wrong, or did you ever doubt yourself, and did you believe that you shouldn't be doing those things? Or
I mean, I made quite a lot of mistakes along the way. I think it was never really about trying to prove people wrong. I think it was about, here is a challenge that I would like to do. And it's not because I want to prove anybody wrong, it's just, this looks like a really cool opportunity for me. And there are all these sort of barriers to entry, and I want to overcome that to do this. And how can I do that, really? And as I said, I made a lot of mistakes along the way. I wore some pads which I really shouldn't have worn in water obstacles, and, you know, accidents galore. But it was a case of learning, and I've now got to the point where I've taught my continence team, if you have anybody else that comes with these issues and wants to do this, this is my personal plan that could work for them. So it's been a really nice learning curve, actually, for both the team and for me. But I think that's a really great thing from them, is that they've been willing to learn from me, as well as me taking on their feedback.
So I suppose really the healthcare professional and the patient is a learning experience for everybody, isn't it? Everybody's individual, and we learn together, and we might not get it right first time, but I suppose it's that open dialogue, isn't it? And you having full understanding, us having full understanding of what you want to achieve as well.
Yeah, completely.
So obviously, you being a keen athlete, it must have been hard at times to obviously think that you were going to achieve what you wanted to achieve. What support was available to you?
Me, myself, and I. I think it was me, myself, and I. I think through my sort of obstacle racing, I entered a really supportive community at the time, and they were incredible at seeing me as a person, and not a disabled person, but just as a person. I think that really helped. In terms of official support out there, I just was very self-sufficient, shall we say. In order for me to have my amputation, I had to have about 18 months worth of counselling. So I kind of had been through the counselling side of things and that support. And interestingly, even through the counselling, I never opened up about my continence issues because I just never felt confident about it. But what I found actually is, since being open about it, it has really helped. It really, really helped tenfold. You know, I don't have any issues talking about it. If I want to ask my workplace for some facilities to be put in place, I feel really confident about that. Whereas before, I would have really been hiding it. And don't get me wrong, I don't like post it everywhere. No. But it's nice to be able to have those conversations with people, because ultimately you kind of need to. Yeah,
brilliant. And I suppose we've talked a bit about factors affecting wound healing, factors affecting continence, the fact that as nurses, and I've learned so much tonight from listening to you, that we need to delve deeper into you as an individual. But is there anything that you would suggest to a healthcare professional, or even a patient that is going through any kind of health condition, that they should talk to us more, or what questions we should ask you guys, those open questions to get the dialogue going?
Yeah, I think from a patient's perspective, I think it's definitely about not being afraid. I think we have these preconceptions that people are going to judge you and that people are going to think that you fit into this one box, but actually that's not the case at all. As I said earlier, any time I've opened up about my continence issues, I have never had a problem with anybody giving me any negative feedback. And I've really, really feared that, and it's never been the case. So it's been really eye-opening, and I think for any patient, don't be afraid to talk about it.
Yep.
because the fear that you have is all up here.
Yeah.
Everybody opens you with open arms, and it's a really fantastic way to offer support, and getting it off your chest can just make such a difference.
Brilliant. Thank you, Jamie. Thank you. That's brilliant. So what we're going to do now is,
Sure.
obviously, before we move on to the live Q&A, guys, where you can pose questions to myself and Jamie, we're just going to summarise the session. So, in summary, I think we'll all agree that obviously patients' health needs can be very complex, and despite it being a condition that probably we see regular, it will be unique to them as individuals. So we have to remember that when we're dealing with them. We need to understand that all the factors that may impact on their health and well-being can be a challenge, but it's important we understand so that we can help improve outcomes. And to improve self-care, we need to delve deeper into their capabilities and concerns so that partnership planning can be successfully achieved. Now, it might be actually, and we were talking about this earlier, weren't we, that there may be patients that actually just want us to take them and do everything and just take over, and that's fine. But then there is patients like yourself, Jamie, that are inspired and you want to know everything, you want to do as much for yourself as possible, which is great. And I suppose it's really as opening up our minds, I suppose, and identifying which category people sit in, and it's not black or white, there's a very grey area there as well. And I think you'll all agree that Jamie is a great example of how life goes on. And it doesn't have to limit you when you're faced with health-related conditions. So from an Essity perspective, we have lots of support tools available, and I wanted to obviously first highlight the best practice statements. So there's 2 key best practice statements that obviously can help from a wound care perspective and also help from a male continence perspective. The Improving the Assessment of Chronic Wounds is a really useful document. It talks about the whole of the assessment process for wound healing. It also talks about what the patient's expectations are, so that's a really useful document. And then hot off the press is the best practice statement for male continence problems. As we've identified, it is seen as a predominantly female condition. It's actually classed as a disease as well, isn't it now? It's not actually a condition, it's classed as a disease in its own right. And so this best practice statement talks about what is best practice for male continence, and has some really unique case studies in there as well that will help with obviously putting strategies in place to help support the male population. Obviously at Essity we have a range of therapy solutions to help support all our healthcare professionals, and we cover continence and skin care. We also have advanced wound care, leg ulcer management and chronic edema. So particularly we have the Tenor Wash 3-in-1 formula to promote skin health, ideal for cleansing and hydrating that delicate and fragile skin, and it's a no rinse formula as well. We also have a range of Tenor absorbent products on the market as well through the new Tenor Pro Skin range with the high leakage security. We then move on to our advanced wound care, because obviously tonight's been a combination of both. So we got advanced wound care products with our Cutimed range, and so we cover everything from infection management to exudate management and skin protection. So we have the Sorbat technology range, which is a antimicrobial dressing that actively attracts and binds bacteria and fungi to the dressing and reduces that bacterial load. And then we have our absorbency products, so our Cutimed Sorbian and Cutimed Siltec. So Cutimed Sorbian is our super absorbent dressings, and our Cutimed Siltec is our foam dressings. We also have a compression therapy range as well, so the Jobs range, and they range from bandages, wrap compression systems, and hosiery kits, and obviously that supports the lymphology and the vascular patients. And then finally, we have our academies, and we're here to help you with education. All our academies are CPD accredited. Obviously today we only touched on the surface of some of the factors that will affect wound healing and continence. But if you are interested in any more generic education, as you can see, there is a few topics on here. We have a total of up to 50 modules available, but maybe ones that might be of interest will be things like anatomy and physiology of the skin, maybe factors affecting wound healing. We have a surgical site infection module, and then we have things like introduction to continence and dementia and incontinence, which may be interesting as well. Obviously, if you're interested in anything that SCT can offer in terms of the best practice statements, which we can obviously get for you, and also any of the product range, you can contact SCT and the details are on the screen now. So let's move on to our first question. Firstly, we wanted Jamie to know how many people have commented to thank him for sharing his story and have said how inspiring he is. Now on to our first question. So Jamie, this one's for you. So this is from Cora. How did your body image affect you while you were going through the worst moments?
Ooh, that's a really interesting question. I think as a young guy, body image is always something that's an issue. Or something that we don't necessarily want to raise as an issue. And I think that in some respects, because I had a foot that didn't work for me at all, and it was very difficult walking around with a foot that I almost didn't feel associated with. I almost felt a disconnect with my body. I didn't feel like my body and my head were in the same sort of line, if that makes sense. So I think in some respect, because of that disconnect, I didn't have many issues with body image because I was just so disconnected from it. I knew that eventually, if I just kept my head down and kept persevering, I would find a solution that meant that I wouldn't have those body images.
Brilliant, thank you. Thank you, Cora. So question 2. So Jamie, in your opinion, how can we nurses help you and others going through your emotional issues? That's a nice question.
Yeah. I think offering the support and really being open to giving that support and having those open questions that ask, how are you doing? And if someone says, yeah, I'm doing okay, actually, are you doing okay? And really picking that patient as, in some patients you can probe like that. In some patients, obviously, if they say they're okay, they are
Leave them alone,
But I think getting to know your patient, which is obviously very restricted with time, etc. But as much as you can in that appointment, try and get to know your patient and offering them support if they do need it. And being open to, yes, there are other issues that come with continence, whether it's sort of fertility or anything like that. I think it's really you need to open people's minds as to, okay, you might be okay right now, but if you ever come across any of these things, then here are the numbers that you can contact, and we are here for you.
Brilliant, thank you. Okay. So, question number 3. Do you have any phantom pain?
It really comes and goes.
Okay.
Really, so generally no. Generally I have phantom sensations, so I can feel certain bits, but pain-wise, no. I mean, I was sat in a lecture the other day and my stump just started twitching out of nowhere, which has been driving me crazy. But, I get sensations which last for 5 seconds, cramp off, and then crack on with my day.
Did you get phantom pain post-surgery? Is that...
I did initially.
Yes.
And it just calmed down after a while. It calmed down
over time.
Yeah.
Brilliant. Okay, question 4. For me. Okay. How can you help support patients to make sure they're properly hydrated, even they are suffering from incontinence? I think sometimes in terms of hydrating patients, it's about education, isn't it? I'm sure that you went through the same, where you thought if you restricted your intake, that would make everything go away. I think we see it a lot with the elderly as well, especially if they're on diuretics. The instant thing is, I won't drink today. And then they feel, but obviously what happens is it irritates the bladder lining and then can cause infection. The urine's more concentrated and actually can make the incontinence worse. Did you find?
Yes.
Find that.
Yep.
So I think we need to ensure that we make sure that patients are fully educated in the fact of what will happen if they don't drink, and not just say you need to drink, because I think it doesn't make sense. It's not logical, is it? You think if you don't drink, you're not going to but actually you will continue, because that's the body's process of elimination. So I think it's all about education. It's all about being factual and keeping it simple as well, and explaining that it's not going to go away that easily, and you still need to drink to ensure that you're hydrated, to ensure that you have overall well-being.
I think there also are some really great practical tips that you can give patients. So, for example, I have a really big Camelback that just has a straw, and I just know that if I have to complete that goal-ticked great, no problem at all.
Yes.
You know, things like drinking through a straw, it's surprising how much liquid you can take on even just through drinking through a straw. So I think the practical side of things can be really helpful for patients as
That's
well.
a really good point, actually. I think if you think of children as well, if you give them a straw, they'll drink what you want them to.
Yeah.
But obviously, if they're drinking out, it seems like they're having to drink more, isn't it, when you're drinking out of a glass?
Mm.
Okay. So a question from Vicky. So our continence assessment in the community is mainly delegates to healthcare professionals due to workload, delegated to healthcare assistants due to workloads. They have minimal training. How do you feel and what can be done to support them? I think a lot of work is being delegated out to other healthcare professionals. I think there is a lot of a big knowledge gap out there, Vicky, if I'm honest with you, generally, whether you're a registered nurse or whether we're unqualified nurses. I think there's a lot more we can do in terms of e-learning. There is Facebook Live, for instance. This has been a great way of people being able to get educated on specific topics. And I think we just need to ensure that we give them the appropriate training that they need to be able to do those assessments properly. It's very hard to expect somebody to go out and complete a continence assessment without actually having all the foundations beforehand, especially when we've heard your story. Like you say, it's those 10 questions, isn't it? And if they're the only questions we ask because we haven't got that further knowledge to divulge. But great question, Vicky, thank you. So, Elaine, so what do you think staff could have done differently to help you in recovering and coping?
I think the hospital I was at did a really great job of offering any sort of psychotherapy. That was really on point. I think as an amputation rehabilitation hospital, they already knew if you come for an amputation, you go and have physio, you go and have psychotherapy, it's great. Yep. Those boxes were ticked. But I think in terms of, I didn't really feel supported as a whole. Yep. And it was great having that psychotherapy available. But as a 22-year-old boy, I didn't want that. I didn't want to say that I wanted that. And I didn't feel as though I had one person that I really felt confident in that I could go and speak to about the issues surrounding the whole picture. Yep. I think having that one person as a support, and I don't necessarily think that was because someone needed to be allocated that role. I just think that had there been someone who came across as really approachable and really open and really bubbly and very open to other ideas, I would have been able to communicate that and I would have got more support, but I didn't necessarily feel like I had that. Yeah,
okay, brilliant, thank you. Thank you, Elaine. So final question of the night. Okay, so this is Maxine for you, Jamie. So what's next? What are your future plans? What a brilliant one to end on.
Ooh, future plans, take over the world. No, I'm joking. In terms of, I've got the World Obstacle Course Race Championships at the end of this week. I've got the World Judo Games next year. Sorry. I want to continue progressing and keep really working on myself and working on how can I progress myself and how can I inspire other people. And as part of this whole Facebook Live, it's about trying to open people's opinions and really trying to get them out of there. This is what a patient should look like. This is what a young man with incontinence should look like. Actually, no, we're completely different. Every patient is different. So trying to open the minds of other people, trying to inspire other people to get involved. Next year, I've got lots of plans to help lots of sort of wheelchair users and other adaptive athletes around different obstacle course races, try and get them involved. And it's just about trying to sort of inspire the next generation and get other people up and moving.
Thank you, and have a really good evening, guys. Thanks.
Thank you.